Alrighty. I think in the interest of time, we might get started. So welcome everyone to the sixth and penultimate virtual ward round this year on haematology. So those of you who I haven't met, my name is Victor and I'm a junior doctor working at the Royal Melbourne Hospital. And in these virtual ward rounds, I will endeavour to provide some practical insight into how theory learnt from medical textbooks can be used to solve real-world clinical problems. In today's lecture, I will take you through two interesting haematology cases, one from the ward and another as a consult. And these two cases are intended to give you a sense of the types of presentations that you'll encounter on a typical haematology rotation, whether you're part of the sort of inpatient ward team or part of the consults team, and how these presentations are usually managed. So as you're no doubt aware, the virtual ward round series is brought to you by Teaching for Impact, a not-for-profit organisation with a mission to use education as a weapon to create meaningful social impact. This year, all of our medicine lectures are being run as fundraising events for the Asylum Seeker Resource Centre, the largest independent human rights organisation for people seeking asylum in Australia. At TFI, we share ASRC's belief that all asylum seekers deserve protection, respect and a chance to rebuild their lives, and invite medical students from across the state to join us in our campaign to make a meaningful contribution towards this worthy cause. So for those of you who are interested in keeping abreast of the tutorials and lectures that our TFI medicine team has to offer, scan the QR code on the right. And as always, I want to keep these sessions relatively informal. So at certain points, I'll put some questions to the floor, and I would love it if you could all contribute answers to the online chat, or better yet, unmute and share your thoughts. So without further ado, so this is our first patient. So Mrs. MN, a 33-year-old female who was referred initially to outpatient haematology clinic by her GP with pancytopenia for investigation. She has no significant past medical history on no regular medications. And she's from home with husband and 3 young children, and doesn't smoke and doesn't drink any alcohol. So a bit more about her presentation. So she presented actually 1 month ago to the GP with pancytopenia, which was associated with some fatigue, reduced appetite, and mild loss of weight. Reports feeling hot, but no subjective fevers or night sweats. She says that she's noticed a blanching erythematous rash over her upper chest anteriorly, which appears to come out at night and subside in the morning. And the rash is not pruritic or painful. She reports no other focal infective symptoms. She has no bruises and denies any bleeding, and she has no headaches. So you do a set of routine bloods, and this is what you find. So she's pancytopenic, so she's anemic with a hemoglobin of 98, and anemia is a normocytic anemia. The MCV is within the reference range. She's neutropenic, and she's also thrombocytopenic as well. Her other bloods are otherwise unremarkable. And as you would expect for a patient presenting with pancytopenia, reflexively, usually the lab there's a lab haematology registrar that has a look at the blood film. And the blood film report said that there were red cells showing moderate anisopoikilocytosis, with some macrocytes, occasional elongated cells, irregularly contracted cells, teardrop cells, rare nucleated red cells, and mild polychromasia. There's also a left shift in the neutrophils to occasional myelocytes, and there's some dysplastic changes, so hyperpigmentation and agranulation and rare blasts. So the conclusion was leukoerythroblastic features. Now, a couple of big words here. Does anyone know what anisopoikilocytosis means? So it's actually made up of two terms. So anisopoikilocytosis is a combination of anisocytosis and poikilocytosis. So anisocytosis refers to the fact that there are red blood cells of different sizes, as Hanyu has just put on the chat. And poikilocytosis refers to the fact that there are red blood cells of different shapes. And there are various causes of anisopoikilocytosis. A lot of different causes of anemia can cause this kind of presentation, including your thalassemias, etc., etc. So it's quite a non-specific finding. Has anyone heard of teardrop cells and know what the presence of teardrop cells points to or indicates? Yeah. So teardrop cells, also called dacrocytes, usually indicates some level of bone marrow infiltration. And you see it in conditions, and we'll go into this in a bit more detail later in the talk, but conditions like primary myelofibrosis, where your entire bone marrow is scarred up, so fibrosed. And the way that I think of it is that in bone marrow infiltration, the red blood cell sort of sheds a tear, hence teardrop cells, because it's sort of being mechanically squeezed out of its home in the bone marrow, because it's all fibrosed up. And the last, I guess, big word here is leukoerythroblastic features. So leukoerythroblastic anemia refers to the presence of nucleated red cells and early myeloid cells, with or without, can occur with or without anemia. So again, quite a non-specific feature. So causes include bone marrow infiltration. So you can see it in things like primary myelofibrosis. You can see it in severe infection, such as septicemia, or a marked marrow response secondary to severe trauma, shock, or recovery from bone marrow suppression. So I think there's probably there are probably features on the peripheral blood film that suggest that the bone marrow is being infiltrated by something, but I don't think we can point our finger on any condition at the moment. But a patient who presents with pancytopenia always makes you worried about the possibility of blood cancers. And I think in the first half of this talk, I'll spend quite a bit of time giving you guys a conceptual framework for approaching and thinking about blood cancers. I think the first time I learned about blood cancers, I found it very confusing. There are different ways of classifying, blood cancers, and a lot of the blood cancers have very long names that sometimes, don't really make immediate sense. So hopefully, after the end of this first section, you'll be more comfortable with, how different kinds of hematologic malignancies fit in with each other. So a bit of a primer on blood cancers. So blood cancers can be broadly divided into leukemias and lymphomas. And this depends on mainly on where most of the cancer cells reside. So if most of the cancer cells are in the peripheral blood, then a blood cancer is called a leukemia. If most of the cancer cells are in the lymph nodes, then we call it a lymphoma. But it's important to bear in mind that the terms leukemia and lymphoma tell you nothing about the cell from which the cancer arises. So an example would be a chronic lymphocytic leukemia, or CLL, which is a cancer arising from mature B cells. And if most of the neoplastic B cells are in the peripheral blood, then we call it CLL, so a chronic lymphocytic leukemia. But if most of the neoplastic B cells are in the lymph nodes, then we call it a different name. We call it small lymphocytic lymphoma, or SLL, but they're one and the same disease. So CLL and SLL are one and the same disease. You know, it's the same cell giving rise to the cancer. It's just that, you know, when most of the cancer burden is in the peripheral blood, we call it a leukemia, so chronic lymphocytic leukemia. When most of the cancer burden is in the lymph nodes, we call it a lymphoma, so small lymphocytic lymphoma. So I'll first, you know, spend some time talking about how I think about leukemias, and then I'll move on to talk about lymphomas. So I'm going to start by, quickly revising, how blood cells are made. So all blood cells arise from hematopoietic stem cell, and hematopoietic stem cells usually reside in these specialized, niches in the bone marrow, and are actually, quite few and far between. So they estimate that only 1 in every 20 million nucleated cells in the bone marrow are hematopoietic stem cells. And normally hematopoietic stem cells are dormant, but roughly every 20 weeks, hematopoietic stem cells enter the cell cycle and either self-renew or undergo differentiation. And the hematopoietic stem cell differentiates into, 2 main cell types, either a common lymphoid progenitor, CLP, or a common myeloid progenitor, CMP. And the common lymphoid progenitor then gives rise, after multiple rounds of differentiation, to give 3 types of lymphocytes. And what are these lymphocytes? So what are these 3 types of lymphocytes? Or what are the 3 types of lymphocytes? Yeah, cool. Yeah. So, B cells, T cells, and natural killer cells are our 3 types of lymphocytes. I guess, B cells, without going into too much detail, so you might remember from, undergrad immunology, that B cells are born in the bone marrow and then they mature in the spleen and then become activated in the lymph node. And it's in the lymph node that they usually differentiate to give plasma cells. Well, they differentiate to give either memory cells or plasma cells. But plasma cells are the effector cells that secrete, antibodies or immunoglobulin. And usually, after B cells terminally differentiate into plasma cells in the lymph node, the plasma cell then homes back to the bone marrow and just chills there for the rest of its life, just secreting antibodies into the blood. So that's the lymphoid lineage. So the chronic myeloid progenitor also gives rise to 3 types of myeloid cells, so granulocytes, reticulocytes, and megakaryocytes. There are 3 types of granulocytes, and I guess the distinction between them, they serve different functions, but really the distinction between them lies in how they stain on H&E stain. What are the 3 types of granulocytes?
Basophils, eosinophils, and neutrophils.
Yeah, right. Yeah. So if you stain neutrally, then you're a neutrophil. If you stain basophilic, then you're a basophil. If you stain eosinophilic, then you're an eosinophil. Cool. And does anyone know what reticulocytes give rise to?
Red blood cells.
Yep. Yep. So they're immature red blood cells. So what we call erythrocytes. And how about megakaryocytes?
Macrophages.
Yeah. No, not quite.
Oh, like monocytes?
Nope.
Oh no, sorry, yeah, my bad.
Yeah. So platelets. Yeah. So megakaryocytes are these large, large cells that bleb off platelets every now and then into the bloodstream. So yeah, granulocytes, 3 types of granulocytes: neutrophils, basophils, and eosinophils. Reticulocytes are immature red blood cells that give rise to mature red blood cells, which are erythrocytes, and megakaryocytes bleb off platelets. So that's hematopoiesis in a nutshell. And cancer can arise at every stage in this differentiation process. And in general, the earlier on in this differentiation process a cancer cell arises, the more aggressive the leukemia is going to be, resulting in a more acute presentation. But the fact that the leukemia is dividing very rapidly also makes it more susceptible to chemotherapy. So I think 2 principles that you need to bear in mind as we walk through the different types of leukemias. So the earlier on the cancer arises, the more acute the presentation, but the more responsive the cancer is to chemotherapy. Conversely, the later on in this differentiation process a cancer cell arises, the more chronic the presentation, but it's less responsive to chemotherapy, which targets rapidly dividing cells. So hopefully that all makes sense so far. So I'm going to walk through some of the most common types of leukemias now. So firstly, I'm going to talk about what happens when a common lymphoid progenitor becomes cancerous or becomes neoplastic. So if a common lymphoid progenitor becomes cancerous, because it's so early on in the differentiation process, we would expect an acute presentation. But the cancer is more likely to be responsive to chemotherapy. And hence, we call this kind of cancer an acute lymphoblastic leukemia. Acute because it's highly aggressive and it presents acutely. Lymphoblastic because it comes from a common lymphoid progenitor, and leukemia because assuming that the most of the cancer burden is in the peripheral blood, then we call it leukemia. Of course, ALL can also present, with most of the cancer burden in the lymph nodes as well, in which case we call it an acute lymphoblastic lymphoma, which is often shortened to LBL, so lymphoblastic lymphoma, but they are one and the same disease, depending on where the majority of the cancer burden resides. So ALL, I'm not going to spend too much time talking about ALL because ALL is largely, unless there are people here who are interested in pediatrics or are thinking about a career in pediatrics, because ALL is largely a pediatric malignancy. So if you do an onc rotation at the Royal Children's, you'll see a lot of patients with ALL. But if you're working on the haematology unit at, say, Peter Mac or Royal Melbourne, it will be quite rare for you to see a case of ALL. And about 75% of cases of ALL occur in children less than 6 years old. But this is not to say that adults can't get ALL. And indeed, epidemiologically, there is a second peak of incidence in adults older than 60 years of age. And usually, adult onset ALL signals, worse prognosis. But the majority of ALL cases occur in small children. I guess, the presentation of ALL, really the presentation of all acute leukemias is fairly similar. So obviously it's an acute leukemia, so patients tend to present quickly. And what I mean by quickly is they tend to present over days to weeks. And they present with, quite predictable symptoms. So if you can imagine, ALL is pretty much a common lymphoid progenitor that usually resides in the bone marrow, going rogue and dividing out of control. So in that instance, you would expect, the bone marrow to be very quickly crowded out by the cancerous common lymphoid progenitor, so that there's no space for other blood cells to be born or to be formed. So, so you would expect patients to present very quickly with pancytopenia. So anemia because red blood cells can't form, neutropenia because neutrophils can't form, and thrombocytopenia because megakaryocytes and therefore platelets can't form as well. And so, patients will present with symptoms of each of these three things. So they would, they'll present with anemia, which will result in things like fatigue, pallor, shortness of breath, dizziness, etc., etc. They'll present with symptoms of neutropenia, which usually manifests as infections or weird and wonderful infections, and also symptoms of thrombocytopenia as well. So easy bruising, bleeding, etc., etc. Now, because you have a rogue cell dividing very, very rapidly in the bone marrow, sometimes that can cause a bit of a lesion in the bone marrow and cause bone pain. The other thing is that sometimes because the other blood cells that are usually formed in the bone marrow aren't able to be formed in the bone marrow, sometimes you'll get a certain level of what we call extramedullary hematopoiesis. So bone cells being formed elsewhere in the body where they were formed when we were fetuses. So these include in organs such as the liver, the spleen, the lymph nodes. All of these are lymphoid tissues in which blood cells can be formed. And then so often you will see patients presenting with enlargement of those organs as a result of extramedullary hematopoiesis. So hepatomegaly, splenomegaly, and/or lymphadenopathy. The last group of symptoms that patients with acute leukemias can present with, and usually this is proportional to how rapidly, how high the cell turnover is, and in acute leukemias, the cell turnover is very high. In such cancers, you would expect patients to present with B symptoms. And B symptoms is usually a constellation of symptoms that was previously used to refer to the clinical presentation of lymphomas. But often, patients with acute leukemias also present with B symptoms as well. And I'm wondering, if people here know what I mean by B symptoms. There are 3 B symptoms. And there are actually quite specific criteria as to what technically classifies as a B symptom versus just a constitutional symptom, which is a systemic symptom that doesn't strictly meet B symptom criteria. So do people know what the 3 B symptoms are? Yep, so fever greater than 38 is the first B symptom, and it has to be greater than 38. Drenching night sweats, and Meg is right, like drenching night sweats is not, the kind of night sweat that you get, from just leaving the heater on all night. It's drenching, so it drenches through the patient's clothing and onto the sheets, and the sheets are wet. And so that's, yep. And then there's specific weight. The third B symptom is that there's specific B symptom criteria for how much weight loss and over what time period, classifies as a B symptom amount of weight loss. So it's unintentional weight loss of greater than 10% over the last 6 months, as Vivian has pointed out. So first is fever greater than 38. Secondly, it's drenching night sweats. And third is unintentional weight loss of more than 10% over the last 6 months. So, and as I alluded to, symptoms that don't strictly meet B symptom criteria, we just call constitutional symptoms. So, ALL. Again, I'm not going to talk too much about ALL, but I guess a fun fact that you guys should know is that there are many different types of ALL corresponding to different chromosomal translocations. I think there are two that are if you do find yourself on an onc rotation at a pediatric hospital, you will see these two types of ALL. So one type of ALL is associated with a translocation between chromosome 12 and 21. So a T translocation 12-21 ALL, and that's 25% of pediatric ALLs are positive for this translocation, and it's usually so translocation 12-21 is usually thought of as a good prognostic marker. So patients with ALL who have this translocation tend to do quite well. The second type of ALL that you will see, and this accounts for 25% of adult ALL cases, is ALL that's positive for the Philadelphia chromosome. So, and do people remember what translocation is associated with the Philadelphia chromosome? Yeah, so translocation between 9 and 22, so T922. So this is the second type of ALL, accounts for a quarter of adult ALL cases, and so usually Philadelphia chromosome. When we think about Philadelphia chromosome, we think about CML, so chronic myelogenous leukemia, but it can occur also in acute lymphoblastic leukemia as well, and that's usually associated with worse prognosis. So Philadelphia positive ALL is bad, and usually occurs in adults. And does anyone remember the fusion protein that's created when you translocate, when you get a translocation between 9 and 22? Yeah, BCR-ABL. So that's right, and that's significant because it guides therapy. So just like in CML, where almost all patients have the Philadelphia chromosome, in Philadelphia chromosome positive ALL, because patients harbor this, express this BCR-ABL fusion protein, you can treat it using tyrosine kinase inhibitors. Things like imatinib and dasatinib and whatnot. So the treatment of ALL, again, this is getting a little technical, but it really depends on whether the patient has Philadelphia negative or Philadelphia positive ALL. So Philadelphia negative ALL, we usually treat using a 3-drug regimen. So one drug is called vincristine, which is a vinca alkaloid. The second is corticosteroids, and the third is asparaginase. And sometimes we can add an anthracycline to high-risk patients. So sometimes it becomes a 4-drug regimen. And I know these are all like chemotherapeutics with very big and long names, but you will see these names again and again and again. And certainly they're part of more than one chemotherapeutic regimen. So I'm going to keep referring back to some of these medications. So Philadelphia negative ALL, we treat using 3 drugs: vincristine, corticosteroids, and asparaginase. And vincristine, do people know? So vinca alkaloid. So there are two main vinca alkaloids, vincristine and vinblastine, both of which are very commonly used in chemotherapeutic regimen. Do people know what the main side effects are of vinca alkaloids?
Peripheral neuropathy.
Yeah, great, yeah. And more so with vincristine than vinblastine. So the way that I think about it is vincristine crisps the nerves, so causes axonal neuropathy. And vinblastine tends to more commonly cause myelosuppression. And the way that I remember is vinblastine blasts the marrow. So vincristine crisps the nerves, but vinblastine blasts the marrow. So that's Philadelphia negative ALL. Philadelphia positive ALL, we still use that 3-drug regimen, but we also add a tyrosine kinase inhibitor. like imatinib or dasatinib. It's purely because we can, and tyrosine kinase inhibitors have shown again and again that they're very, very effective in killing off Philadelphia chromosome positive cancer cells. So that's ALL. Now going back to our diagram. So earlier on, the cancer arises, the more aggressive, but the more responsive it is to chemotherapy. So if you have a cancer cell arising from a common myeloid progenitor, then you'll expect an acute presentation. So it's an acute leukemia. And because it arises from a myeloid progenitor, we call it an acute myeloid leukemia or acute myelogous leukemia. And AML is actually, the most common kind of acute leukemia in adults. So AML has been associated. A lot of different things have been shown to cause or contribute to the risk of developing AML, including some environmental factors like chemicals, radiation, smoking, chemotherapy, viruses, retroviruses as well. But in some instances, AML actually evolves from a precursor condition called myelodysplastic syndrome. So when you think about MDS, so myelodysplastic syndrome is essentially what the name suggests. So it's a condition where the myeloid cells or the myeloid progenitors in the bone marrow have become dysplastic. They haven't become cancerous, but they're screwed up in some way. So they've become dysplastic. And if they get more hits, so if they accumulate more mutations, then they eventually evolve to become AML. So just like colonic polyps can evolve to give you colorectal cancer, MDS can evolve to give you acute myeloid leukemia. So think of MDS as a precursor condition for AML. And I'm not going to go through sort of the presentation of AML. It's very, very similar to acute lymphoblastic leukemia. So everything I said for ALL applies to AML. AML in particular, though, has been associated with several life-threatening complications that require emergent treatment. And there are two in particular that I want to pay special mention to. So the first complication is something called hyperleukocytosis. And hyperleukocytosis, as the name suggests, is a complication that arises because there are so many white blood cells in the blood. And in the setting of AML, it's usually defined to be a white cell count of above 100. And up to 20% of patients with AML present with hyperleukocytosis. And hyperleukocytosis, you can sort of imagine if you have so many leukocytes in the blood, it tends to crowd out the peripheral blood and make the peripheral blood quite thick. So it results in something which we call leukostasis. So there's so many sort of leukocytes in the blood that it causes a bit of a traffic jam for leukocytes. And so the blood slows down, and this can cause end organ damage. And the two organs that are usually affected in leukostasis is respiratory, the lungs and the brain. So it can cause respiratory distress, and it can also cause neurological distress as well. And its endpoint can cause comas. Do people know how we might treat hyperleukocytosis? So there's a medication called hydroxyurea that we often think about as a medication that can reduce cell counts in the blood, so causes cytoreduction. So really, the treatment for hyperleukocytosis is hydroxyurea that can really help to bring down the white cell count in the blood. Now, so that's the first complication that AML is commonly associated with, and indeed, the first presentation of AML can be with hyperleukocytosis and leukostasis. The second complication is something called tumor lysis syndrome. And can someone, maybe this requires a bit of explanation. Is someone game enough to sort of unmute and potentially explain what tumor lysis syndrome is?
So I'm not necessarily sure in this context without giving chemotherapy, but I know when you give high doses of chemotherapy, you can get the tumor or the cancer lysing, and then a release of electrolytes which can accumulate. So you get high potassium, high phosphate, low calcium, high urea. So it can cause like end organ dysfunction with the urea causing renal damage and things like that. But
yeah, absolutely. Not so much urea as uric acid, but the other electrolytes are spot on. So TLS or tumor lysis syndrome, we usually find in the context of just after initiating chemotherapy in acute leukemias like AML, and it's as Meg said, it pretty much is a consequence of leukemic cells all dying very rapidly at the same time, which causes everything that was originally inside of cells, like potassium, phosphate, usually in the form of ATP, and uric acid. All of those things get released, in one big dump into the blood, as a result of all of these cells just dying in one go. And obviously, potassium, when you get so much potassium being released into the blood, that's bad for the heart. Phosphate, the risk of high phosphate in the blood is that, the phosphate can bind and co-precipitate with calcium. So hyperphosphatemia tends to cause hypocalcemia. And there's a little trick that you can do, on ward round to predict, I guess, the risk of, this precipitation, this co-precipitation of calcium phosphate happening. So when you take the calcium and you multiply it by the phosphate, and if it's greater than 5, if that product is greater than 5, then you're at high risk of the phosphate binding to the calcium and co-precipitating out. The bad thing about calcium phosphate crystals is that it deposits in the kidney and can cause kidney damage. And the final sort of thing that gets released into the blood is uric acid. So it can cause hyperuricemia. It's been known to actually cause acute gout flares. But the other important thing is that uric acid crystals also, just like calcium phosphate crystals, deposit in the kidney and can cause kidney damage. So generally speaking, the best treatment for tumor lysis syndrome is actually prevention. And we take pains to prep the patient prior to chemotherapy to minimize the risk of TLS. You guys know what's involved in TLS prophylaxis? Freya has predicted my question. Yeah. So allopurinol, so any urate lowering agent like allopurinol, sometimes rasburicase is used. But that's one component. The second component is aggressive fluid hydration to make sure that the kidneys undergo as little damage as possible from tumor lysis. But yeah, so AML is classically associated with hyperleukocytosis and leukostasis, and also secondly, tumor lysis syndrome as well. Yeah, calcium. So it's called the calcium phosphate product. So you take the calcium and you multiply by the phosphate, and then if it's greater than 5, then you worry about phosphate binding to calcium and precipitating out as calcium phosphate crystals. But that's just a really quick way to sort of predict the likelihood of someone of calcium phosphate crystals forming in the blood of someone. Now, do people know how we treat AML? And Freya, yes, the fluid hydration is IV. Yes, TLS can occur spontaneously, especially in acute leukemia. So acute leukemia, the blood cells can actually outgrow themselves and then all die off because they're growing so quickly, but they're also apoptose very quickly as well. So it can occur in the absence of chemotherapy, but most cases of TLS is caused by chemotherapy. So yes, treatment, most common treatment for AML. So it's, chemo and BMT. So have people heard of 7+3 therapy? So my computer's running out of charge again. 7+3 therapy. So 7+3 therapy refers to a chemotherapeutic regimen where so it's 7 days of continuous infusion of a chemotherapeutic agent called cytarabine, otherwise known as ARA-C, so ARA -C. So cytarabine or ARA-C. So that's the 7-bit. So 7+3. The 3-bit is 3 days of anthracycline. There are really 2 main anthracyclines that we use in the cancer space today. One is called doxorubicin, and the other is called daunorubicin. So 7+3 therapy is the most commonly used chemotherapeutic regimen to treat AML. So it consists of 7 days of cytarabine, otherwise called ARA-C. And then for the first 3 days, you give anthracycline, an anthracycline as well, most commonly doxorubicin. And just wondering, do people know what the main side effect of anthracyclines are, doxorubicin? It classically, heart failure. It causes dilated cardiomyopathy. And so often we need to follow these patients up with serial TTEs to monitor for dilated cardiomyopathy. But yeah, that's 7+3 therapy.
Can I ask a quick question, Victor?
Yes.
Is it are there cycles of it? You know how like with RCHOP for DLBCL it's 6 cycles and things like that. Is it the 7+3 therapy? How many times?
It's just one. It's just one cycle.
Okay.
Often that's enough. So in about in up to 80% of patients, especially if they're young, they go into complete remission after 1 cycle of 7+3 therapy. Great. Which is, I guess, the good thing about that's the good thing about acute leukemias. I mean, acute leukemias, they either kill you or they're really responsive to chemotherapy, and the majority of the patients recover and go into complete remission. Yeah. You know, obviously, if you don't go into complete remission after one cycle of 7+3 therapy, often, you know, hematologists will give you another round of 7+3 therapy, and usually that does the trick. And then, you know, the usual, you know, principles of treating leukemias is that there's 3 phases of therapy. So there's an induction phase, and the aim of the induction phase is that you hit them with you know, incredibly aggressive chemotherapeutic agents to induce, and the aim is to induce complete remission. And then the second phase is the consolidation phase, where you hit them with something less hard, but to really sort of round out the complete remission. And then there's maintenance therapy, which tries to, you know, keep patients in remission. So for AML, usually the induction regimen is 7+3 therapy. So 7 days cytarabine, 3 days anthracycline, either doxorubicin or daunorubicin. And then the consolidation phase, so in 80% of patients that achieves complete remission. And then the consolidation phase is usually just single agent cytarabine, although administered at a slightly higher dose, so high dose cytarabine. And then, you know, often in AML, maintenance isn't really required, but you can, you know, there are certain categories of AML that can benefit from maintenance therapy after consolidation therapy.
Thank you.
Yeah, no worries. And I guess, you know, before we move on from AML, there's one subtype of AML that I think deserves special mention. So prior to 2001, so now you know, we all use the WHO classification for hematologic malignancies, but prior to 2001, AML was actually classified using a system called the French American British classification system, or the FAB classification system, so French American British. And this classification system categorized AML into 8 different subtypes based on morphology alone. And the 8 subtypes are named M0 all through to M7. So there's the M0 subtype, M2 subtype, M3 subtype, et cetera, all the way up until M7. And the M3 subtype refers to a specific kind of AML called acute promyelocytic leukemia, or APL. And I think this subtype deserves specific mention because, you know, although technically it's a subtype of AML, APL actually has quite a distinct presentation. So often it presents with DIC, so disseminated intravascular coagulation. And it's treated very differently as well. You'll never treat an APL patient with 7+3 therapy. And this is because it's associated with a very specific translocation. Does anyone know, for you know, brownie points, does anyone know what that translocation is that's associated with APL? RARA. Yeah, good. So it's translocation 1517, and it results in the expression of a fusion protein called PML-RARA. And the significance of PML-RARA is that it stops granulocytes from differentiating. And it results in these cells that have these rod-like structures in them called AUR rods. So AUER rods. And this is, a very popular sort of medical student exam question where they show you a peripheral blood film and it's some myeloblasts with some AUR rods inside them, and they ask you what the diagnosis is. So AUR rods equals to acute promyelocytic leukemia, which is the M3 subtype of AML, and it's very different because it's associated with 1517 translocation, resulting in PML-RARA. Do you guys know how to treat it? So the principles, the principles are to so PML-RARA causes differentiation arrest. So the granulocytes stop differentiating. and so they're stagnant at the precursor sort of state, and then they start dividing out of control. The way to treat APL is to actually give them a medication that will stimulate differentiation again. And the medication that you give is vitamin A, otherwise known as all-trans-retinoic acid, or ATRA. So as Meg and Mon have indicated. And yeah, so plus or minus arsenic dioxide, so ATO as well. And in very high risk APL patients, we would use anthracycline therapy. But hold that thought. I will probably revisit this later on in the talk. But yeah, so just remember, AML we usually treat using 7+3 therapy. There is a specific subtype of AML, which is the M3 subtype, which is APL, which is special because it involves a 15-17 translocation resulting in PML-RARA and the presence of ALRODs, and it can be treated with ATRA, plus or minus arsenic dioxide, so plus or minus ATO, and sometimes anthracycline. Cool. Hopefully, yes, you treat the DIC first, or else the patient will die. But part of the treatment of DIC is to treat the underlying condition that's causing the DIC, because DIC has a
like, do you start it like straight away in ED, or would you like just stabilize the patient, get them up to the ward, and then work out the hematological treatment, the underlying cause treatment?
Yeah, depends on their whether they're hemodynamically stable or not. But often you need to treat the DIC first. Yeah, and usually ATRA therapy is commenced on the day, potentially concurrent with giving them transfusions to treat their DIC, either on the day or the next day. Because if you delay treatment at all, so APL is considered a medical emergency. So if you delay treatment at all, the patient will die within days. So why is AML associated with? So yeah, leukostasis. You can get leukostasis and PLS in ALL as well. Yeah. The mechanism why that's probably beyond me. But yes, there's a stronger association with AML than with ALL, but I'm not actually sure what the reason is. Cool. Okay. So hopefully I haven't lost anyone. So those are the acute leukemias. Now going back to our principles, the later on a cancer arises, the more chronic the presentation, but the less responsive the cancer is to chemotherapy. And so if you have a cancer arising from B cells, so mature B cells, because mature B cells are quite late in the differentiation process, you would expect it to be chronic in presentation and less responsive to chemotherapy. So we call this kind of leukemia chronic lymphocytic leukemia. And just a reminder that the distinction between leukemias and lymphomas is actually pretty arbitrary, right? If most of the CLL cells are in the peripheral blood, then we will call it a chronic lymphocytic leukemia. But if it's mostly in the lymph nodes, then we will call it SLL, so small lymphocytic lymphoma. But CLL, SLL, they're one and the same disease. So in contrast to ALL, which is mainly a pediatric malignancy, CLL is considered mainly a disease of older adults, and the median age of diagnosis is probably around 70 years. Now, epidemiologically, I think CLL is a good one to remember. ALL you can get away with not really knowing, because unless you go into pediatrics, you're not really going to see a case of ALL. CLL is worth knowing because CLL is the most common adult leukemia in Western countries. So you will see a lot of these. Uncommonly, they will be sick enough to be admitted. Usually to initiate therapy and for a period of monitoring before you send them home. Often these patients can be managed in the clinic, though, and some of them we don't even treat at all. And I'll talk about that. If you're asymptomatic, we don't really treat CLL. So we talked about the presentation of acute leukemia. Let's talk about the presentation of chronic leukemias as well now. So in contrast to acute leukemias, patients with chronic leukemias present insidiously. And what I mean by that is they present over months to years, sometimes decades in the case of CLL. And so indeed, the vast majority of CLL patients are actually asymptomatic at diagnosis. And the most common way in which CLL is diagnosed is a patient going to their GP for a routine FBE, and then the GP discovering that their lymphocyte count is very elevated, but the patient doesn't feel a thing. And then they refer the patient to a hematologist, and then they get a bone marrow biopsy and they diagnose CLL. So that's really the most common way in which CLL presents. Now, sometimes, and especially in patients where the majority of the cancer burden is in lymph nodes, so really we should be calling these patients SLL patients, they present with lymphoid tissue enlargement, so lymphadenopathy, splenomegaly, and hepatomegaly. And I think out of those three organs, probably lymphadenopathy is probably the most common. And it's often in the cervical area, so painless lymphadenopathy in the cervical region. Often it's spontaneously waxes and wanes, but doesn't altogether disappear. And then the spleen is probably the second most frequently enlarged organ, and then the liver is the last one. Now, just as patients can present with a lymphocytosis, the lymphocytosis is often enough to cause bone marrow failure. So what we mean by bone marrow failure is crowding out of the bone marrow so that other cells can't be formed. So patients can present with anemia, neutropenia, thrombocytopenia, or symptoms thereof as well. I think the thing to know about CLL is that it's often, so the anemia that you get from, if you have a CLL patient that has anemia, the anemia could be from CLL infiltration of the bone marrow, so crowding out of the bone marrow so that red blood cells can't form, or it can be due to a secondary autoimmune hemolytic anemia. So sometimes in CLL patients, the immune system is all screwed up and starts to produce autoantibodies that target antigens on the red blood cell surface, and that can cause hemolysis, which can cause anemia, so autoimmune hemolytic anemia. And we will talk about this a little more later on in the talk. But just note that CLL often causes a secondary autoimmune hemolytic anemia. Now, so how do you diagnose CLL? So usually, you do an FBE and that shows lymphocytosis, and usually the absolute B lymphocyte count is greater than 5 by 10 to the 9 per liter. So that's the cutoff that the IWCLL, the international workshop for CLL, that's the cutoff that they use. And that's the cutoff that all hematologists, or almost all hematologists, use to diagnose CLL. So more than 5 by 10 to the 9 B cells in the blood. Reflexively, the lab hematology registrar will have a look at the blood film, so the peripheral smear. And what's classic about the blood smear of CLL patients is that you get these things called smudge cells or basket cells, and I have a picture of smudge cells there with conveniently placed arrows to highlight what they look like. I guess do you guys know how to treat CLL? So the first things first, if the patient is asymptomatic, we don't treat it. We just monitor it with serial FBEs. But what if the patient is symptomatic? We all know how to treat CLL. Yeah, cool. So so in fit and healthy patients that don't have disease markers that predict for poor response to chemotherapy, and there are several of those markers which I'll talk about a little later. But so in young medically fit patients with none of those adverse prognostic markers, we can use FCR. So FCR is very, very effective at eliminating CLL in these patients. Usually the age cutoff, there's an age cutoff for FCR. So in patients that fit all of those criteria that are less than 65 years of age, we use FCR, which is a combination of fludarabine, cyclophosphamide, and rituximab. In older than 65 years, in patients older than 65 years, FCR is considered too toxic. And so we tend to use another chemotherapeutic regimen called BR, so bendamustine and rituximab. Now, before I go on, so yeah, in young, in medically fit patients, without those, nasty adverse prognostic markers, if they're less than 65 years, we'll use FCR to treat them. If they're greater than 65 years, we'll use BR to treat them. Now, so fludarabine, cyclophosphamide, rituximab, fludarabine you'll probably see commonly. Cyclophosphamide is probably more commonly used in other chemotherapeutic regimens. Do people know what cyclophosphamide is and what kind of side effects cyclophosphamide has? Yeah, great. Yeah. For those of you who haven't Googled Chemo Man, please do so now. So Chemo Man is a great way to remember chemotherapeutic side effects of chemotherapeutic agents. But yeah, so cyclophosphamide, there's also another related drug called ifosfamide. And together they form a class of agents called nitrogen mustards. And the way they act is that they cross-link the DNA and then causes DNA damage. There are various adverse effects of cyclophosphamide. I think the thing that you should know is that it causes hemorrhagic cystitis, as Meg pointed out. And sometimes that predisposes patients to developing bladder cancer. And so routinely we try to prevent hemorrhagic cystitis using a medication called Mesna, so MESNA, to prevent hemorrhagic cystitis. But anyway, so treatment of CLL, that's only in a very small subset that we will tend to use FCR and BR. And about probably 10, 15 years ago, that those were probably the only drugs that we can use to treat FCR. But we very quickly realized that yes, in some patients, FCR and BR are very effective in clearing CLL cells. But there were some patients that tended to respond very poorly to these kinds of chemoimmunotherapeutic regimens. And these are usually patients with abnormal TP53. So, TP53, guardian of the genome, et cetera, They can have abnormal TP53 either through, mutations in the TP53 gene, or they can have deletion of 17p, which is the chromosome on which TP53 resides. So these patients usually respond really poorly to FCR and BR. So that's one adverse prognostic factor. The other adverse prognostic factor is IGHV status. And this comes, so requires a bit of knowledge of B cell immunology, but B cells, are born in the bone marrow and then mature in the spleen and then are activated in the lymph nodes. And then in the lymph nodes, they form a germinal center and then undergo somatic hypermutation and isotype switching. And then they differentiate into plasma cells. So after a B cell undergoes somatic hypermutation, the variable region of their heavy chain becomes mutated. So their IGHV mutated. If you have a B cell that hasn't yet undergone somatic hypermutation in the germinal center, then their IGHV is unmutated. So the variable region is unmutated. And going back to our principle that the earlier on a cancer arises, the worse the disease. If the CLL cell, if they are IGHV unmutated, which means they haven't undergone somatic hypermutation, they are. It suggests that the CLL has arisen from an earlier B cell that hasn't undergone somatic hypermutation, so it signals badness. Whereas if the IGHV status is mutated, then it means that the cancer has occurred a little later after the B cell has undergone somatic hypermutation, and so the prognosis is better. So the other class, apart from TP53 abnormal, patients, the other class of, patients that tend to respond poorly to immunotherapy is those with unmutated IGHV. And in these patients, in the past, about 10 years, we've seen the emergence of, really 3 groups of targeted agents that have been shown to be very, very effective, just as effective as FCR and BR in people with either an abnormal TP53 or unmutated IGHV. And the 3 targeted agents are: 1, a BCL2 inhibitor called venetoclax. I guess this drug is probably, this drug is probably of most interest because, it was developed at the Walter and Eliza Hall Institute in Parkville, and the first in-human trial was run at Peter Mac in Royal Melbourne. This is a drug that was essentially invented in Melbourne. So that's one class of agents that you can give. The other you can give to patients with these adverse prognostic markers. The second is BTK inhibitors. So BTK stands for Bruton tyrosine kinase, and there are various agents under this class of medications. Ibrutinib is probably the first in class, and then there are other sort of novel BTK inhibitors like zanubrutinib and acalabrutinib, et cetera. The new guy on the block is something called pirtobrutinib, which is still in clinical trials but showing great efficacy in poor prognostic, in CLL with poor prognostic markers. And the third group of agents is anti-CD20 and antibodies. So rituximab is the first in class in this group of drugs. There's now a next generation anti-CD20 antibody which apparently is better, called obinutuzumab. So poor prognostic features, there are 2 of them, 2 main ones. So one is abnormal TP53 via either TP53 mutations or a deletion in 17p, chromosome 17p. So that's the first one. And the second one is unmutated IGHV, which suggests that the B cell from which the cancer arose has not yet undergone somatic hypermutation, and so it's a little earlier. Cool. So that's how you treat that's how you treat CLL. Very exciting space, especially for the Melburnians. The other thing that yeah, Freya, there are many poor prognostic markers in CLL. I think I just focused on two of them, the main ones. But the last thing that I want to say about CLL is that there's a thing called, so CLL is usually quite an indolent disease, but every now and then CLL can transform into an aggressive lymphoma, most commonly DLBCL. Diffuse large B-cell lymphoma, and I'll talk about that in more detail later. This is when CLL transforms into an aggressive lymphoma, we call it Richter transformation. So Richter is a guy's name, R-I-C-H-T-E-R. So you will see that word being used a lot on hematology units, Richter transformation from CLL. And that's sadness. Patients usually die within months if they develop Richter transformation. Okay, so the last one is, again, following the principle, so the later on the cancer arises, the more chronic the presentation, but the less responsive it is to chemotherapy. So if you have neutrophils becoming cancerous and giving rise to a cancer, then we call it chronic myeloid leukemia or chronic myelogenous leukemia. I won't say too much about this because I think this one should be relatively familiar for most people here. So this is the one that's associated almost universally with the Philadelphia chromosome, so T922, resulting in the expression of BCR-ABL1 fusion protein. So in the absence of treatment, so typically CML takes a triphasic or a biphasic clinical course. So the three phases are, firstly, the chronic phase, which 85% of patients are in at time of diagnosis, and then that can evolve into an accelerated phase in which neutrophil differentiation becomes progressively impaired, and the leukocyte counts become more difficult to control with treatment. And then where you're really screwed is if the CML goes into blast crisis, which is a condition resembling acute leukemia, in which the myeloblasts proliferate in an uncontrolled manner. So the diagnosis of CML is confirmed by demonstration of the Philadelphia chromosome. So if you have Philadelphia chromosome, and typical findings on bone marrow examination, then you've clinched the diagnosis of CML. And we treat it using TKIs, tyrosine kinase inhibitors, so imatinib, dasatinib, et cetera. So blast crisis is different. So blast crisis, the term blast crisis is only used in the context of CML to I guess refer to, you can think about it as transformed CML. So CML transformed to AML, whereas Richter's transformation is CLL transformed to an aggressive lymphoma, usually DLBCL, sometimes a Hodgkin's lymphoma. So they're subtly different. One is CML specific, the other is CLL specific. Okay, I am very quickly running out of time, so I won't belabor the point. So before I move on to lymphomas, I want to briefly talk about two other groupings of hematologic malignancies that sometimes confuses students. So the first is plasma cell dyscrasias, and the second is myeloproliferative neoplasms. So firstly, plasma cell dyscrasias, we know that B cells terminally differentiate to give plasma cells, cancers arising from terminally differentiated plasma cells are collectively referred to as plasma cell dyscrasias. And there are two types of plasma cell dyscrasias that you should know about. So the first one, I think, we covered in a bit of detail in a previous talk. It's multiple myeloma. So things that you need to remember about multiple myeloma, it's when you have a plasma cell that's become neoplastic and is dividing out of control in the bone marrow. So this typically creates an osteolytic lesion in the bone marrow, causing bone pain, and then obviously releases large amounts of calcium into the blood, and that causes hypercalcemia. It also crowds out the bone marrow, so it impairs the bone marrow's ability to form new blood cells, red blood cells. So this causes anemia. The other thing that the neoplastic plasma cell does is it secretes large amounts of either full immunoglobulin or just light chains, or what we call free light chains. Now, when it secretes full immunoglobulin, about 55, most of the time it's IgG. So 55% of the time it's IgG. 25% of the time it will be IgA. It's very, very rarely IgM. So that's full immunoglobulin. If it secretes free light chains, so then we call it Bence-Jones proteins. So free light chains, Bence-Jones proteins, they're the same thing. And the thing with free light chains is that it has a propensity to deposit in the kidneys, and it causes a condition called light chain class nephropathy. And that's the main cause of renal impairment in multiple myeloma. So we just went through the QAB symptoms essentially. So hypercalcemia, renal impairment, anemia, and bone pain, or an osteolytic bone lesion. The other causes for renal impairment in multiple myeloma. So paraproteins usually refers to the full immunoglobulin. Bence-Jones proteins is just the free light chains. So the other thing that can cause renal impairment is the hypercalcemia. So the hypercalcemia also contributes to screwed up kidneys. And I guess when the kidneys become damaged, they also become less able to produce erythropoietin, so EPO, which then worsens the anemia. So I guess it all connects. There are two ways. I think last time we talked about the fact that there are two ways to diagnose multiple myeloma. So the first way is if you have do a bone marrow and you find more than 10% clonal plasma cells, and then plus one of the CRAB features, you can diagnose multiple myeloma. So greater than 10% clonal plasma cells plus one of the CRAB features is multiple myeloma. The second way to diagnose multiple myeloma is via presence of one of the SLIM features. And do people remember what the SLIM features are? So SLIM stands for, S stands for 60. So 60% clonal plasma cells on the bone marrow. The L or Li in SLIM stands for light chain. So if the free light chain ratio is greater than 100, then you can diagnose multiple myeloma. And M stands for MRI. So more than one focal lesion on MRI. You can also diagnose multiple myeloma. And the most common treatment for multiple myeloma, I think we talked about, is VRD therapy. The V stands for bortezomib, which I guess if you think about it, doesn't make sense. But the V refers to the trade name for it, so Velcade, which is bortezomib. Same with the R, refers to the trade name, but that stands for lenalidomide, and then D stands for dexamethasone. So that's multiple myeloma. The second type of plasma cell dyscrasia that you need to know is called Waldenstrom macroglobulinemia. I'm not sure if any of you guys have heard this, but so in Waldenstrom macroglobulinemia, the cell that has gone neoplastic is not quite a plasma cell, but it's a post-germinal center memory B cell that has undergone somatic hypermutation, but hasn't undergone isotype switching. So it's stuck in the IgM state, and it just, so instead of secreting IgG or IgA, as you'll find in multiple myeloma, it just secretes monoclonal IgM. And the thing with IgM is that it forms a pentamer in the blood. So you have this big ass protein in the blood that then causes the blood to thicken. So the presentation for Waldenstrom macroglobulinemia is very different. You won't see crab features. The most common thing that you will see is something called hyperviscosity syndrome, where because the blood is so thick, patients tend to present with things like blurry vision, headaches. They can cause strokes when it's very extreme. But yeah, so I think just distinguish between Waldenstrom's macroglobulinemia, which is usually a post-germinal center memory B cell throwing out IgM, causing hyperviscosity syndrome, and distinguish that from multiple myeloma, which is a plasma cell throwing out IgG, IgA, or free light chains, causing your crab symptoms. The second grouping that I want to talk about is myeloproliferative disorders or myeloproliferative neoplasms, and this is just a name to, I guess, it corresponds to all cancers arising from terminally differentiated myeloid cells. So if you have a terminally differentiated myeloid cell causing cancer, automatically it's get classified under an MPN, so myeloproliferative neoplasm. In the same way, if you have a cancer arising from terminally differentiated lymphoid cells, right? Technically, you can call them lymphoproliferative disorders. So things like CLL, for instance, is technically classified as a lymphoproliferative disorder because it arises from terminally differentiated lymphoid cells. Anyway, focusing on myeloproliferative neoplasms or disorders. So if you have a cancer of the neutrophil, then we call it CML, which we already talked about. You have a cancer of the erythrocytes, then we call it, polycythemia vera, which anyway, I won't go into clinical features because we're running out of time. But if you have a cancer of megakaryocytes, then that causes primary myelofibrosis. And if you have a cancer of megakaryocytes and therefore platelets, then it's called essential thrombocytosis. So together, these four conditions make up your myeloproliferative neoplasms. Often, even when you're on a gen med rotation, often when you have a patient, presenting with an unexplained thrombocytosis or thrombocythemia, so really elevated platelet count, right? Or unexplained erythrocytosis, so really elevated hemoglobin, right? For no reason, right? Often you'll be asked by a hematology registrar to order an MPN screen, which tests 3 gene mutations that the majority of patients with myeloproliferative neoplasms have. Do you guys know what 3 gene mutations I'm referring to? Fantastic. Hey, Lee. Yeah, so JAK2, CALR, and MPL. So those are the 3 things that you test whenever you're asked to order an MPN screen. Anyway, so let's quickly move on to lymphoma, because there is, I want to talk about anemia before we wrap up. So how do we classify lymphomas? Well, typically lymphomas are classified into either Hodgkin's lymphoma or Hodgkin's lymphoma or non-Hodgkin's lymphoma, and that's based on the presence or absence of these cells called Reed-Sternberg cells, which are these distinctive tumor, giant cells, typically, binucleate or bilobed, with the 2 halves as mirror images, resembling, our eyes. Typically CD15 positive and CD30 positive. If you see these owl eyes, these Reed-Sternberg cells, it's automatically Hodgkin's lymphoma. Oops, that could say Hodgkin's lymphoma. So Hodgkin's lymphoma, the most common presentation is asymptomatic lymphadenopathy, most commonly in the neck, but sometimes you can get it presenting as a, when you do a routine chest X-ray, you see this large mediastinal mass. That's also a common presentation for Hodgkin's lymphoma. I guess three things that, very weird, presentations or clinical features that you should be aware of that are associated with Hodgkin's lymphoma. The first is something called Epstein fever. It's a very uncommon but very characteristic presentation in which the fever cyclically increases, then decreases over a period of 1 to 2 weeks. So Epstein fever is quite specific for Hodgkin's lymphoma. The other one is pruritus. Sometimes you can get patients just presenting with itch. I'm not actually sure what the mechanism is. And the third thing, and this is very rare, but again, very specific to Hodgkin's lymphoma, if you see it, is alcohol-associated pain. So severe pain following alcohol ingestion. And the pain usually occurs at site of bony involvement, but it can also occur at the site of lymphadenopathy as well. And although it's very rare, if you have a patient presenting with this, it's highly specific for Hodgkin's lymphoma. Do people know how we treat Hodgkin's lymphoma? It's an acronym for a chemotherapeutic regimen. ABVD, fantastic. So stands for, A stands for doxorubicin, which again doesn't really make sense, but the other way of, other name for doxorubicin is adriamycin. So A stands for adriamycin, which is the same thing as doxorubicin. B stands for bleomycin. V stands for vinblastine, which is one of those vinca alkaloids like vincristine. And D stands for the carbazine. And I'm wondering, do people know, those who have seen the Chemo Man, bleomycin, what does that cause? Side effect wise, in terms of side effect. Yeah, cool. Pulmonary fibrosis. Excellent. Okay, so let's briefly talk about non-Hodgkin's lymphomas. So these are, a lot more common than this should say Hodgkin's lymphoma. So non-Hodgkin's lymphoma is a lot more common. And the way to think about non-Hodgkin's lymphomas is to divide them into indolent ones, aggressive ones, and highly aggressive ones. So there are 4 indolent non-Hodgkin's lymphomas. So the first is CLL/SLL. The second is a condition called mantle cell lymphoma. And the aberration there is that there's a translocation that causes cyclin D1 overexpression, which just drives the cells through the cell cycle like crazy. Follicular lymphoma is the third one. And the main abnormality there is a translocation that causes overexpression of BCL2, which is the protein that's targeted by venetoclax. And BCL2 is a pro-survival protein. So for those who remember from undergrad pathology, it's the pro-survival protein in the intrinsic pathway of apoptosis. So elevated levels of this means that the cell can't undergo apoptosis, and so it's resistant to all signals that usually cause apoptosis to cells. And MZL stands for marginal zone lymphoma. And then there's one aggressive type of lymphoma that you need to know, and that's DLBCL, which stands for diffuse large B-cell lymphoma. And diffuse large B-cell lymphoma, I guess, you should know the treatment for this. And I think someone mentioned it, earlier in this talk. The treatment is R-CHOP. Do people remember what R-CHOP stands for? So R stands for rituximab. C stands for cyclophosphamide. So it's the same cyclophosphamide as in FCR. H, this doesn't really make sense, but stands for doxorubicin. So doxorubicin has a third name. So adriamycin is one name. Doxorubicin is a second name, and the third name is hydroxydownorubicin. So the H stands for doxorubicin. O stands for, and again, this doesn't make sense, but stands for vincristine. And the reason is because the O refers to the trade name called Oncovin. So that refers to vincristine, and P stands for prednisolone. So RCOP, you'll see a lot because DLBCL is the most common type of non-Hodgkin's lymphoma. And it accounts for more than a quarter of cases of non-Hodgkin's lymphoma. And finally, the highly aggressive one, so usually found in adolescents and young adults. So you may or may not see this if you practice as an adult sort of hematologist, is a Burkitt's lymphoma. And Burkitt's lymphoma, the thing to know about that is that it's caused by a translocation that results in overexpression of MYC, which is a oncogene that is referred to a lot in undergrad molecular biology. But it's overexpression of MYC driving the cell through the cell cycle, it classically on bone marrow biopsy, you'll see this starry sky appearance. So the a buzzword for Burkitt lymphoma. Anyway, going back to our case, I'm going to wrap this case up because I want to talk about anemia. So presented with pancytopenia, so we did a bone marrow biopsy, and this is what the bone marrow biopsy looks like. Can someone tell me what the diagnosis is? Yeah, it's APL because the arrows point to the L rods. So yes, APL, translocation 1517, resulting in expression of PML-RARA, which causes arrest of differentiation. The medical emergency you need to treat with ATRA plus or minus ATO. So I guess I said I'll get back to this, but in terms of deciding on initial treatment, we divide patients with APL up into those that are low or intermediate risk, which is defined as patients with an initial white cell count of less than 10 are at low or intermediate risk. And for these patients, we usually treat initially with ATRA plus arsenic trioxide. So whereas patients with an initial white cell count of above 10 are defined to have high risk APL, and we treat these patients with ATRA plus anthracycline. And I guess the thing that you need to remember when you're initiating therapy for patients with APL is a thing which I think is a bit analogous to tumor lysis syndrome, but the pathophysiology is different. The pathophysiology of this condition that I'm going to talk about is a cytokine storm, and it causes something called differentiation syndrome. It's very commonly found in APL patients that first commence on ATRA therapy. Differentiation syndrome, and it occurs in about 25 to 50% of patients with APL, and usually it can occur within days, so 2 to 21 days after initiation of treatment, and is seen more frequently with patients with high risk APL, so have an initial white cell count of above 10. And it's characterized by things like fever, peripheral edema, pulmonary infiltrates, hypoxemia, respiratory distress, hypertension, renal and hepatic dysfunction, and serositis, sometimes resulting in pleural effusions. And a lot of these, features can mimic a septic shock, but really it's because of a cytokine storm, and we call it a differentiation syndrome. And the treatment for that is dexamethasone, using steroids to calm the cytokine storm down. Now, because of time, I'm not going to go through the questions, but I'm going to post the recording of this up on YouTube, so you guys can have a go at these questions in your own time. The second case that I wanted to talk about is a consult, and it's a 54-year-old female that was on the Gen Med ward then then transitioned over to the rheumatology ward. And it's a female with systemic lupus erythematosus. That at the time of the hematology referral was under hospital in the home for warfarin dosing for secondary antiphospholipid syndrome. Remember, antiphospholipid syndrome goes hand in hand with SLE. And the presentation is, the reason for the hematology consult was new anemia. The baseline hemoglobin was for this patient was about 115. And suddenly, over the course of days, it plummeted to a hemoglobin of 68. And the hospital and the home doctors had no idea what was going on. And so called in the hematology registrar. What you need to know about this patient is that, past history SLE, previously treated with hydroxychloroquine and mycophenolate mofetil. As antiphospholipid syndrome had previous, DVTs and PEs and also an ischemic stroke. This patient also has secondary ITP, so idiopathic thrombocytopenic purpura, which often again co-occurs with SLE. Before I move on, hydroxychloroquine. So there are three main indications, three main conditions where you would see hydroxychloroquine being used as a therapy. So the first is malaria; it's an anti-malarial. Secondly, it's rheumatoid arthritis, and thirdly is SLE. The thing that you need to know about hydroxychloroquine is that it's remarkably effective in things like rheumatoid arthritis and SLE, but it has quite a narrow therapeutic index. And I'm wondering if people know what the main side effect of hydroxychloroquine is. Yes, retinopathy, great. It's called chloroquine retinopathy. So just remember, hydroxychloroquine is bad for the eyes. And, as you would expect, this patient developed macular degeneration as a result of hydroxychloroquine use. And so hydroxychloroquine was stopped, and then mycophenolate mofetil was initiated, and then she didn't tolerate that. And so, she was started more recently on azathioprine. Hypertension is the last one. The patient, here are the patient's list of medications. Lots of hypertensive, drugs like lercanidipine, irbesartan, etc. And the hypertension was probably so. Why would this patient be on prednisolone? Actually, that's an unfair question. I think I'm asking you guys to read by mind. But prednisolone was given for the ITP. But one side effect of prednisolone is that it increases your blood pressure. And so it worsened the hypertension. And so this patient was initially on single agent lercanidipine, but then we needed to keep on adding antihypertensives because we were placing this patient on high dose prednisolone. Azathioprine, as I said, was recently initiated for this patient for treatment of SLE. I'm wondering, so I think one thing that I want you guys, I don't remember if I talked about this in a previous talk, but azathioprine is a prodrug. And I've done a very simplified sketch of how azathioprine is metabolized. But basically, in the liver, it's metabolized to 6-mercaptopurine, and indeed, 6-mercaptopurine is itself used as a medication, often in IBD. And it can then 6-mercaptopurine can be metabolized via one of 3 different pathways. So two of those pathways inactivate 6-mercaptopurine, and one actually converts it to the active agent called 6-thioguanine. So the way to inactivate 6-mercaptopurine is, xanthine oxidase is an enzyme that can convert 6-mercaptopurine into an inactive metabolite. The other enzyme that can do that is TPMT. Two ways of inactivating 6-mercaptopurine. Now, the thing that you need to know about azathioprine is that before commencing patients on azathioprine, you would see rheumatologists routinely ordering a TPMT genotype. And that's trying to test for whether the patient is wild type or whether the patient has TPMT mutations. Because if you can sort of see from this diagram that if the patient has TPMT mutations that knock out TPMT, right, then all of the, or well, a lot of the 6-mercaptopurine will then get shunted into this active ingredient, and patients will present with azathioprine toxicity. So usually we don't like to give people with TPMT mutations azathioprine. So you need to check TPMT genotype before commencing azathioprine. The other thing that I wanted to relay is that so there are some xanthine oxidase inhibitors that we use to treat gout, that we use for hemolysis prophylaxis, syndrome prophylaxis as well. So allopurinol, things like febuxostat, they're all xanthine oxidase inhibitors. And so xanthine oxidase inhibitors like allopurinol have the same effect as TPMT mutations. So if you have an inhibitor to xanthine oxidase, you knock out xanthine oxidase, and a lot of the 6-mercaptopurine will then get converted into this active ingredient, and patients will get azathioprine toxicity. So two things to get out of this, I guess. Before starting any patient on azathioprine, please do a TPMT genotype. And the other thing is never give allopurinol and azathioprine in the same patient, because the patient will be at high risk of developing azathioprine toxicity. And why is azathioprine toxicity so bad? What are the side effects of azathioprine? Yeah, myelosuppression. Agranulocytosis, fantastic. It's also very bad for the liver, so it causes hepatotoxicity. And the last one is that it's one of those, and I think last talk, the Gen Surge talk, I talked a bit about pancreatitis and drug-induced pancreatitis. Azathioprine is a class 1 drug that has a very high potential, great potential to cause pancreatitis. Cool, so that's a bit about azathioprine. Now, the other, before I move on, dapsone. I talked about dapsone, I think, in a previous talk as well. Why might this patient be on dapsone? Can someone hazard a guess? PJP prophylaxis, good. Because if you look at the allergies, the patient is allergic to Bactrim. And indeed, 30% of patients with SLE are allergic to Bactrim. And so often we need to resort to second-line PJP prophylaxis dapsone if we're putting patients on high-dose drug prednisolone for more than 2 weeks. So, and you should recall that the cutoff for when we might consider starting patients on PJP prophylaxis, it's 20 milligrams of prednisolone for more than 2 weeks. Some people say 20 milligrams for more than 4 weeks. This patient was started on 67.5 milligrams of prednisolone from memory, and then slowly tapered out. But yeah, was receiving prednisolone, very high doses of prednisolone for many months for her ITP. Cool, and warfarin, obviously it's for the antiphospholipid syndrome. And I think I mentioned in a previous talk that warfarin is much better than a DOAC for antiphospholipid syndrome. So you never put a patient with antiphospholipid syndrome on a DOAC. It's always warfarin. Cool. So yeah, a little bit more about her history, I guess. So she had a recent admission with a subacute microhemorrhage to the cerebellar vermis, and then during her admission, she subsequently developed multiple small infarcts to various parts of her brain. Her admission was complicated by difficult to control hypertension and ITP, which made managing the ITP very difficult, because the way to manage ITP is prednisolone, and prednisolone increases the blood pressure. So this patient was at the time, this is the first time that haematology was called in to review the patient for ITP, and we only provided some phone advice. So was started on 67.5 milligrams daily. It's usually a 1 milligram per kilogram daily of prednisolone is the dose. So 67.5 milligrams daily of prednisolone for ITP. And then there was a plan to wean the prednisolone very slowly at a rate of 5 milligrams per week, so long as the thrombocytopenias don't worsen. This patient was allergic to bacterium, so we commenced her on dapsone for PJP prophylaxis, was TPMT wild type, so we commenced her on a low dose azathioprine for her SLE, as guided by rheumatology, with a plan for a slow wean. And then since discharge, her hemoglobin had been downtrending. So her baseline was like 115, but then it reached a nadir of 68. And so the patient was readmitted from HIF to Gen Med for management of the anemia, and Gen Med called the haematology. Now, I want to talk about anemia in the 10-15 minutes that we have left. So when I think in medical school, when you have lectures about how to approach anemia, often you're told, okay, look at the hemoglobin, there are certain cutoffs for hemoglobin that would define anemia. And then the next thing that you look at is the MCV to determine whether the anemia is microcytic, normocytic, or macrocytic. So from my experience, that's not actually a very good way to approach anemia. The reason is because often you can get patients with, say, iron deficiency anemia, which is a microcytic anemia, present concurrently with B12 deficiency, which is a megaloblastic, macrocytic anemia. And so, often, that averages out, and the patient would present with a normocytic anemia on average. And then, if you just rely on, the MCV to work out causes, often you'll be led down the wrong path. So I prefer, so that's what we call the morphologic approach to anemia. I prefer a more practical approach, and the approach that I'm going to talk about is called the kinetic approach to anemia. And this makes more sense to me because it's based off the mechanism. So if you think about the causes of anemia, right? So anemia is, not enough, red blood cells. And you can have not enough red blood cells for 3 different reasons. So you can be losing red blood cells, so increased loss, and you can be bleeding from any orifice. Or you can be low in red blood cells because you're not producing enough red blood cells. And there are various causes of this. So you can be not producing enough red blood cells because your bone marrow is screwed up, and your bone marrow can be screwed up for many different reasons. So MDS is one, so myelodysplastic syndrome, the precursor to AML, can screw up your bone marrow. There's something called aplastic anemia that can also screw up your bone marrow. Things like primary myelofibrosis can screw up your bone marrow. Really, any bone marrow infiltrated disease. So you can have CLL that crowds out the bone marrow and then doesn't give enough space for erythrocytes to be born. That can cause decreased production. So the first cause is bone marrow failure. The second cause for decreased production is hematinic deficiencies. So there are 3 hematinics: iron, B12, and folate. You need this. These are like sort of the ingredients that you need to use to make red blood cells. And if you don't have enough of them, then you won't make that much red blood cells. The other one is EPO sort of deficiency or resistance. So if you have renal disease and you're not producing enough EPO, then that can cause decreased production. If you have EPO resistance, that can cause decreased production. And some drugs can cause bone marrow suppression. So Bactrim can cause bone marrow suppression. And various chemotherapeutic agents can cause bone marrow suppression as well. So that's decreased production. The third mechanism is increased destruction. And what we're referring to there is red blood cells lysing, right? So that's the other third mechanism for how you can lose, or how you can get low red blood cell counts. Now, the way that I think about increase, so what essentially we're referring to is hemolytic anemia, so hemolysis causing anemia. And I divide hemolytic anemia up into two broad categories. So the first category is immune mediated, so what we call autoimmune hemolytic anemia, and I referred to this when I was talking about CLL. So there are two types of autoimmune hemolytic anemia, one called warm autoimmune hemolytic anemia, and one called cold. You can call it cold autoimmune hemolytic anemia, or sometimes it's referred to as cold agglutinin disease. It's the same thing. So the mechanism there is that you get autoantibodies being generated that bind to red blood cell antigens on the red blood cell surface. In warm autoimmune hemolytic anemia, the autoantibody is usually IgG in flavor, and IgG is most active at 37 degrees. And so at 37 degrees, the IgG autoantibody will bind to, antigens on the red blood cell surface. And then, in the spleen, you have splenic macrophages that have receptors on them called FC gamma receptors. And they can recognize the FC portion of the IgG autoantibody that has bound to the surface of the red blood cells. And so the splenic macrophage will then bind and then phagocytose just a portion, just part of the red blood cell membrane that contains the IgG autoantibody, right? Just to get rid of the autoantibody. And so, you get a chunk of red blood cell membrane being bitten off by the splenic macrophage. And then the red blood cell then, reconstitutes its shape and it forms a sphere. And so you get spherocytes. So these are called spherocytes. And spherocytes, red blood cells aren't meant to be, spheres. They're meant to be biconcave discs. And so they're not very flexible. And so they get sheared when they try to squeeze through the spleen. So this is a cause of extravascular hemolysis because it's not technically in the blood vessels. It's in the spleen that this hemolysis happens. And yeah, it typically causes spherocytes. You see spherocytes on blood film. And it's called warm autoimmune hemolytic anemia because IgG autoantibodies, which are the culprit antibodies, are most active at 37 degrees, so at warm temperatures. This is different to cold agglutinin disease, where the pathophysiology is pretty similar. So in cold agglutinin disease, the autoantibody is IgM in flavor. And so you still get, the thing with IgM, in contrast to IgG, the best temperature, the temperature at which IgM is most active is 4 degrees. Now, obviously, there's no part of the body that's 4 degrees, but it gets activated at the colder parts of the body. So usually it gets activated in the peripheries of the body. And in the peripheries, you get these IgM autoantibodies being activated and binding to antigens on the surface of the red blood cell. And then what happens is that, because all of this, the IgM autoantibodies firstly cause agglutination of red blood cells in the peripheries, and that causes cold-induced symptoms. So you can get things like acrocyanosis, livedo reticularis, and Raynaud's syndrome in cold agglutinin disease. And then the other thing that IgM autoantibodies do is that it activates the classical pathway of complement activation. And what that does is that it results in deposition of C3b on the red blood cell surface. And the thing, there are cells in the liver called Kupffer cells that express a receptor to C3b called complement receptor 1 or CR1. And that binds to the C3b that has been deposited all over the red blood cell surface. And then that results, usually the Kupffer cells actually phagocytose the entire red blood cell rather than just a portion of the red blood cell membrane, as in warm autoimmune hemolytic anemia. So this is still an example of extravascular hemolysis because it doesn't occur in the blood vessels, it occurs in the liver. But it's called cold agglutinin disease or cold autoimmune hemolytic anemia because IgM is more active at colder temperatures, and so you get these cold-induced symptoms in the periphery, which you don't get in warm autoimmune hemolytic anemia. And if you so if you think about it, you won't expect to see spherocytes in so much in cold agglutinin disease because the Kupffer cells phagocytose the entire sort of red blood cell. But yeah, you can it's an example of extravascular hemolysis. Now, so that's one cause of increased destruction. So autoimmune mediated. Now, all of the other ones are non-immune mediated causes of increased destruction. And the way to distinguish between autoimmune hemolytic anemia and all these other causes is using a test called the direct agglutinin test, or DAT, which is called the Coombs test. And that allows you to distinguish immune causes of hemolytic anemia from non-immune causes of hemolytic anemia. And usually on the DAT report, if you order a DAT, the report will tell you whether the DAT is positive overall or not. And it will specify the pattern of positivity. So, whether it is positive for IgG or whether it's positive for C3b. So when interpreting DAT reports, the first thing that you look at is whether the DAT is positive overall. And if it's positive overall, then you know that the mechanism is autoimmune hemolytic anemia. If it's not, then the mechanism is a non-immune mechanism. And the second thing that you look at is whether it's positive for IgG or C3b. And if it's positive for IgG, it is warm autoimmune hemolytic anemia. If it's positive for C3b, then it's cold agglutinin disease. And you treat it differently. So warm autoimmune hemolytic anemia, we treat using steroids. So steroids plus rituximab. And then if the patient doesn't respond, then there are other ways. You can do a splenectomy because the hemolysis occurs in the spleen. If you take out the spleen, it stops the hemolysis. Cold agglutinin disease, we tend to treat using, so the first thing is cold avoidance. So hematologists here, in people with cold agglutinin disease would often routinely recommend patients, travel up to Queensland and live in Queensland instead because of the warmer climate. And that sort of, reduces the risk of, IgM activation and cold-induced symptoms. In addition to that, we usually treat using BR therapy, which is the other therapy for CLL, so bendamustine plus rituximab. So out of the non-immune mechanisms, so I'm not going to talk too much about these membrane defects, enzyme deficiencies, and hemoglobinopathies. So that's when the red blood cells intrinsically screwed up, and then when they pass through microvascular, because they're screwed up in structure, they will lyse. So what I want to focus on is microangiopathic hemolytic anemia, which is it's all in the name. So microangiopathic means that the microangio, so the microvasculature is pathic, so it's screwed up. And it's because the microvasculature is screwed up that you're getting hemolysis. So when the red blood cells pass through the screwed up microvasculature. And there are three types of MAHA, so microangiopathic hemolytic anemia, three causes. So they are TTP, HUS, and DIC. So TTP stands for thrombotic thrombocytopenic purpura. I guess, so a primer on TTP, usually endothelial cells produce this a protein called von Willebrand factor. And that's usually synthesized as a polyprotein and then that's anchored to the endothelial cell and then extruded into the lumen of the blood vessel. And then, so it's initially synthesized, von Willebrand factor is initially synthesized as a polyprotein. And then it requires an enzyme called ADAMTS13, so ADAMTS13, that's produced by the liver to cleave the von Willebrand factor into individual monomers. And then the von Willebrand factor, floats away and then, performs the important function of binding factor VIII in the blood. Now, in TTP, there's severely reduced activity of ADAMTS13, the enzyme that usually cleaves von Willebrand factor, a polyprotein, that's usually anchored in the endothelial cells into monomers. And so if you don't have enough ADAMTS13, then you have these like long seaweeds, protruding out of endothelial cells into the lumen, that's remaining uncleaved. And, that causes quite a bit of obstruction. And so platelets that pass through that microvasculature with all these long seaweeds of von Willebrand factor and polyproteins then get caught in these polyproteins, resulting in a platelet-rich thrombus being formed. And because platelets are being trapped in this thrombus, it gets taken away from the circulation, and so patients present with thrombocytopenia. And then the part, so that causes the microvasculature to be very screwed up. You have these long seaweeds protruding into the lumen, and then you have thrombus on top of that because platelets are getting caught. And then when the red blood cells traverse through this platelet-rich thrombi, it gets shredded up, and that results in red blood cell fragmentation. And red blood cell fragments is what we call schistocytes. So you'll commonly see schistocytes on blood film, and that causes the microangiopathic hemolytic anemia. TTP is the presentation is a classic pentad. So I'm wary of the time. I won't ask the question of what the pentad is, but I remember it as FAT-RN. So F stands for fever. A stands for anemia, so microangiopathic hemolytic anemia. T stands for thrombocytopenia. R stands for renal failure. And N stands for neurologic symptoms, so headaches, confusion, seizures, etc., etc. You diagnose TTP by measuring the activity levels of ADAMTS13. If it's less than 10%, then you can diagnose TTP. But usually that takes a couple of days to come back, and you can't afford to wait when you have a patient that has TTP. It's a medical emergency that's almost always fatal if you don't initiate treatment promptly. And do people know how to treat TTP, what we give? So it's plasma exchange, plasmapheresis. So you can't wait. If you suspect TTP, patient presenting with the pentad, classic pentad, you can take blood, send away for an ADAMTS13 level, activity level, but then before the results come back, place patients on plasmapheresis, or the patient's going to die while you're waiting the results. So HUS stands for hemolytic uremic syndrome, and hemolytic uremic syndrome is caused by an infection. So it's caused by Shiga toxin producing E. coli, and there's one that we worry about most commonly called EHEC. So if you've done the 5 pathotypes of E. coli, EHEC is one of them, also called O157H7, the serotype. It mostly presents in children, but can present in adults. And typically, children with HUS, they typically have a prodromal illness that consists of, so the usual story is, they went to a, McDonald's, had a burger, the beef, was slightly undercooked, and they get this diarrheal illness. So abdominal pain, vomiting, usually bloody diarrhea. And then, if the infection is caused by EHEC, then the EHEC starts producing the Shiga toxin. And then 5 to 10 days later, the Shiga toxin starts to act. And then suddenly the patient presents with microangiopathic hemolytic anemia, thrombocytopenia, and then AKI. And clinically, hemolytic uremic syndrome is quite difficult to distinguish from TTP. But in contrast to TTP, so the only way to really distinguish between TTP and HUS is that in TTP, usually neurologic symptoms predominate, Whereas in HUS, usually renal failure predominates because shiga is directly toxic to the kidneys. In contrast to TTP, which is a medical emergency, HUS is a self-limiting illness that's managed by supportive care. So, if the patient's very anemic, then you can give red blood cell transfusions, but mainly it's, IV fluids, right, to treat the AKI. So because it's so difficult to distinguish between HUS and TTP, usually, if you have a patient presenting with MAHA, thrombocytopenia, and AKI, we treat it as though it is TTP. So we commence plasmapheresis, and then we can send some stool cultures and PCR, and then when you plasmapherese the patient, and then a couple of days later the stool culture and PCR will come back. If it's positive for Shiga toxin producing E. coli, then you can cease therapy and you just continue supportive treatment. The last microangiopathic hemolytic anemia is DIC. So this is when you have a trigger, so usually either sepsis or trauma or APL, so acute promyelocytic leukemia, or some other cancer. Causes activation of the coagulation cascade. You have widespread clotting, and then you have rapid consumption of all your clotting factors that outpaces the liver's ability to produce these clotting factors. And so after clotting, you then bleed out and die. DIC is a very dangerous presentation. It's often the presentation that you find in acute promyelocytic leukemia. The management includes, one, treating the underlying condition to eliminate the stimulus. And then you give, if the platelet count is really, really low, less than 20, and the patient is seriously bleeding out, then you give them platelet transfusions and fresh frozen plasma. But usually these things are, initiated, concurrently. And the other things I think is that some drugs and infections can cause hemolytic anemia as well. So, given all of that, right, how would you approach anemia, such as in this patient? What test would you order to try to work out what the cause of this patient's anemia is? And I'm not sure if people have a provisional diagnosis already for this patient, but we can work through it. So anemia, so usually, hemoglobin less than 100, we worry about anemia. When I ask, people, oh, what's the next test that you'll order in a patient with anemia? Often patients will say, oh, we'll just look at the MCV. But as I said, the MCV, it's not very, informative. To work out what the cause is, the next best test to do is to order a reticulocyte count. And usually reticulocytes, the reference range is from 10 to 100. And if you're anemic, but your bone marrow, which is the factory that produces more red blood cells, if your bone marrow is working properly and you're anemic, you would expect that the bone marrow will be working in overdrive to try to I guess fix the anemia. So it will push out lots and lots of reticulocytes that hopefully will mature to give more erythrocytes. So if your bone marrow is healthy and you're anemic, you would expect the reticulocyte count to increase. So above 100. So if you do a reticulocyte count and it's increased, so it's above 100, then that tells you that the bone marrow is working fine. And so the cause is not necessarily decreased production. It's either increased loss or it's increased destruction, right? So the next thing that you do is a hemolytic screen to work out whether it's, whether the patient is losing blood, and that's the cause of their anemia, or whether the patient is hemolyzing, right? And can someone tell me, there are 5 components to a hemolytic screen, and this is something that you will be asked to do again and again and again as a junior doctor. What are the 5 components of a hemolytic screen? Great. Yeah, so it's an FBE is the well, the first two are kind of a giveaway. We already talked about it. So FBE to diagnose the anemia, and then you'll look at the blood film. Some features of the blood film are quite informative. So, for example, if you see spherocytes on blood film, then you're thinking warm autoimmune hemolytic anemia. If you see schistocytes or red blood cell fragments on the peripheral blood film, then you'll be thinking more like MAHA. It might be TTP or some other MAHA. So that's the first test. So FBE plus a peripheral blood film. The second is the reticulocyte count, which we talked about. And then there are three others that tell you that the patient is hemolyzing. So one is the LDH, as people have mentioned. So LDH is something that you find, an enzyme that you find inside of cells. And so if you have red blood cells lysing everywhere in the blood, in the peripheral blood, you would expect them to be dumping a lot of LDH into the blood. So LDH will be expected to be increased. Haptoglobin is a molecule that binds free hemoglobin. So free hemoglobin in the blood is toxic. So you don't want free hemoglobin. And so you have this haptoglobin molecule that usually binds and mops up free hemoglobin in the blood. Now, so if you're hemolyzing, you're releasing a lot of free hemoglobin into the blood. Haptoglobin will bind to a lot of them, and then will be taken out of because they bind, they're taken out of circulation. And so you would expect a drop in haptoglobin when you're hemolyzing, right? Because a lot of them are binding to free hemoglobin. And the fifth component is unconjugated bilirubin. I'm sure you guys, this won't come with a routine LFT. So if you order an LFT, it will just give you a total bilirubin. You need to specifically ask for, so total bilirubin is unconjugated plus conjugated bilirubin. So if you want the unconjugated bilirubin, you need to specifically request for that test. And unconjugated bilirubin, it's a pre-hepatic cause of jaundice. It will be expected to be elevated when you're hemolyzing. And so hemolysis screen, 5 components: FBE plus blood film, reticulocyte count, LDH, haptoglobin, and unconjugated bilirubin. And a positive hemolytic screen is when the FBE shows anemia, the reticulocyte count is increased, meaning that the bone marrow is working properly. LDH is increased because lots of red blood cells are lysing and dumping LDH into the blood. Haptoglobin is decreased because a lot of the haptoglobin is binding to free hemoglobin and getting taken out of circulation. And unconjugated bilirubin is increased. And so if you have a combination of that, it means that the patient is hemolyzing. Now, some people, iPhone mentioned DAT. So DAT is not technically part of the hemolysis screen because the DAT or the Coombs test doesn't. So DAT is used to distinguish between, once you know that a patient is hemolyzing, the patient could be hemolyzing because of an immune mechanism or a non-immune mechanism. And the DAT is to distinguish in patients who are hemolyzing, whether the mechanism is immune or not, whether the patient has autoimmune hemolytic anemia or some non-immune mediated hemolytic anemia like MAHA. So it's not part of the screen. It's not it's not part of the series of tests that we do to determine whether a patient is hemolyzing. But once we know a patient is hemolyzing, we can order a DAT to distinguish between immune and non-immune mechanisms. So the next test. So if you have a positive hemolytic screen, the next test you would order is a DAT. If it's DAT positive, then we know that it's autoimmune hemolytic anemia. As I said, then you look for the patinose positivity. If it's IgG positive, then we know it's warm autoimmune hemolytic anemia. We'll start steroids and rituximab. If it's C3b positive, then we know it's cold agglutinin disease. Then we will send the patient up to Queensland and start bendamustine plus rituximab. Hopefully that makes sense. If it's DAT negative, then we know that it's not immune mediated. So it's all these other causes, MAHA, membrane defects, etc. It could be drugs, infections, etc. If you're actually suspecting MAHA and it fits with the clinical picture, then yeah, you would order an ADAM TS13 activity level. And then if you're strongly suspecting TTP strongly suspecting TTP, then you'll commence plasmapheresis. If you're suspecting HUS, then you might send a stool culture and PCR, and it will return, positive for Shiga toxin producing E. coli. DIC, the hallmark of DIC is a decreased fibrinogen, and that's available on a routine coagulation profile. So cool. So, and if the hemolytic screen is negative, then you know that the patient isn't hemolyzing and that the patient is actually bleeding from some orifice. And so you should look harder for a source of bleeding. Now, so that's if the reticulocyte count is increased, so above 100. Now, the other scenario is when the reticulocyte count is low, so less than 10, or inappropriately normal. And we say inappropriately normal because in an anemic state, you would expect the reticulocyte count to be high if the bone marrow is working properly. So if the reticulocyte count is low or inappropriately normal, then you know that the bone marrow is screwed up. So the causes are these things, right? Bone marrow failure syndrome, not enough ingredients, hematinics, to make red blood cells. It could be EPO deficiency caused by renal disease or EPO resistance, or it could be drugs that's causing bone marrow suppression. So what do you do next? Well, the next sort of easy test to do is send off iron studies and send off vitamin B12 and folate levels. And iron studies might reveal iron deficiency anemia. So I won't talk too much about this because we're running out of time, and I apologize for going over time. But iron deficiency, there are essentially two ways that you can diagnose iron deficiency on iron studies. So there are 5 components to an iron study that you need to interpret. So one is ferritin level, which is, and ferritin is the I think of as a factory or warehouse that stores the iron, so it's a storage molecule. The second component is transferrin, which I think of as the truck, is the transport molecule that transfers the iron from the factory to the cells to be utilized. There's thirdly transferrin saturation, or the TSAT, which is I think of as the percentage of trucks that are filled with iron. So if the transferrin saturation is 100%, then all of the transferrin or all of the trucks are filled with iron. If the transferrin saturation is 30%, say, then only 30% of the trucks are filled. The fourth test is the total iron binding capacity, or the TIBC, which is a measure of how tightly the iron binds to the truck or to the transferrin. And then the fifth component is the most useless test, which is the serum iron, which it doesn't tell you anything. So the most interesting components of the iron study is one, ferritin level, and secondly, the transferrin saturation. And so in iron deficiency, there are 2 ways to define iron deficiency. One is low ferritin, so less than 30 is iron deficiency, full stop. The next way, the second way, and often we need to use this second way to diagnose iron deficiency. The reason is because I think I mentioned in a previous talk that ferritin is an acute phase reactant. So if the patient is inflamed or has an infection on board, then ferritin will be elevated. And so that that can mask a low ferritin, baseline ferritin. So in that case, we diagnose iron deficiency based on TSATs, so transferrin saturation, and a transferrin saturation of less than 19% diagnoses iron deficiency. So 2 ways to diagnose iron deficiency. One is serum ferritin of less than 30, and the second is a TSAT of less than 19%. So going back to our case, this is the bloods. Can someone tell me what the cause of this patient's anemia is? So walking through it, FBE shows anemia, cool. We expect the reticulocyte count to be high if the bone marrow is working. It is high, so the bone marrow is working. So the causes now are, either the patient is bleeding or the patient is hemolyzing. So the next step is to order a hemolysis screen. And this is the hemolysis screen. LDH is elevated, unconjugated bilirubin is elevated, beta-2 micro is also a marker of cell turnover. So increased reticulocytes. I didn't include the haptoglobin, but the haptoglobin was decreased. So decreased haptoglobin, increased unconjugated bilirubin, increased LDH speaks to a positive hemolytic screen. So the patient is hemolyzing. That is the cause of the patient's anemia. Now, the next test that you will order is a direct agglutinin test, which is also called a Coombs test. And the Coombs test is very unremarkable. Overall, the DAT test is negative, monospecific IgG 0, monospecific C3d 0. So the patient is hemolyzing, but not via an immune mechanism. So this is an autoimmune hemolytic anemia. Okay, so what could it be? So it's not autoimmune hemolytic anemia, so it's these things. Now, the patient isn't presenting with, hasn't got any features of microangiopathic hemolytic anemia. So we're thinking drugs, we're thinking membrane defects. It's quite unusual for patients with these to present this late. The patient was, I think, 54 years old. So we're thinking actually drugs combined perhaps with some inherent enzyme deficiencies. And actually, so the cause of this patient's hemolytic anemia, so beta-2 microglobin globulin is just a marker of cell turnover, is just like LDH. So it's increased when you have a lot of cells being hemolyzed. So it's another marker that cells are being hemolyzed. So this patient was placed on a medication called dapsone. And at the time we commenced the patient on dapsone, we thought we were making a reasonable decision, right? The patient was being treated with high dose prednisolone for many, many weeks, right? Needed PJP prophylaxis, but was allergic to Bactrim. So we couldn't give the patient Bactrim. So the next best thing to give the patient is dapsone for PJP prophylaxis. Now, in a previous talk, I talked about the 5 main side effects of dapsone. The first is hemolysis. So this patient has dapsone-induced hemolytic anemia. And so dapsone-induced hemolytic anemia is more commonly seen in patients with G6PD deficiency. And G6PD deficiency is actually one of those things that can lie, hidden until much later in life. And what we forgot to do in this patient was order a G6PD level prior to starting the patient on dapsone. So if you would have ordered a G6PD level in this patient, we would have found out that this patient was in fact G6PD deficient, and so was at high risk of dapsone-induced hemolytic anemia, and we would have not given dapsone. But we forgot to do that, and the patient presented with dapsone-induced hemolytic anemia. And just to complete the story, so dapsone has 5 main side effects. Hemolysis is one. The second one is methemoglobinemia, which we treat using methylene blue. The third is agranulocytosis. The fourth is hypersensitivity syndrome. So sometimes dapsone can cause Stevens-Johnson syndrome or TENS, toxic epidermal necrolysis. And that's usually associated with, so it's more common in Asians. And indeed, this patient was actually Asian, was Chinese. And it's more commonly associated with a specific HLA type called HLA-B1301. So HLA-B1301. And Again, we actually didn't know, we forgot to test for HLA-B1301. So we didn't really know what the risk was that this patient could develop hypersensitivity syndrome from dapsone. And the fifth side effect is peripheral motor neuropathy. And so I guess the learning point from this case is that you should send some pre-dapsone bloods prior to starting any patient on dapsone therapy. So to monitor for agranulocytosis, you should order an FBE with differentials. To monitor for hemolysis, you should order an LFT with unconjugated bilirubin, and also a G6PD level to determine whether the patient is G6PD deficient or not. And if the patient is G6PD deficient, don't start the patient on dapsone, like we did. The fourth pre-dapsone blood that you should do is a HLA-B1301. Now, this some people argue that you should only order this in Asians because it's more common in Asians, but often Caucasians or other ethnicities can present with a HLA-B1301 genotype. So and I believe it's PBS subsidized as well, so it's actually not that expensive a test. So you should order all those things, and if the patient is positive for HLA-B1301, don't start dapsone as well, either, because the patient might get Stevens-Johnson syndrome from it. So yes, that's I guess the learning point from that. Again, I'll post up the recording to this talk afterwards, but you guys can have a go at the quiz in your own time. So that brings us to the end. Thanks everyone for joining, and sorry for going over time. The next talk is on endocrinology, which will be in 2 weeks' time, on the 21st of October, same time, online. In the meantime, hope you guys have a good fortnight, and see you guys then.